everybody. Thank you very much for coming today, and thank you for spending a beautiful Saturday morning in the spring with us. And I'm going to talk today about lifestyle interventions, exercise, and other things like that. I could not find any great studies on acupuncture, so I will not get to acupuncture, but I have a number of others that do refer to pain. And I also did not include wearing cooling vests as well, but I'll talk about a lot of other stuff that are relevant. These are my disclosures. And, we take a large, long view, and that is that the goal of MS therapy is lifelong brain and spine health. And we can get to that a variety of different ways, as noted here. But today we're going to talk about what I refer to as sort of good behaviors, things that, you probably learned from your mother when you were a little girl or boy, and are really relevant to what's helpful for multiple sclerosis beyond the different therapies that we've heard about and potential therapies such as myelin repair and regeneration. So essentially, I'm going to talk about those things that are for which there is data. And I'm going to talk a lot about, as I'll show you in a second, what are known as meta-analyses, and I'll show you how to sort of think about those. And I'm not going to talk about a number of other things, because this would be a 2 or 3 hour talk if you actually did that. So I'm not going to talk about the routine therapies that are prescribed all the time, such as physical therapy, occupational therapy, etc. I'm not going to talk about cannabis. We just heard a little bit about that here, or aromatherapy, and I don't have a slide on acupuncture, although I think it may be useful for pain. So many of the slides I'm going to have here today refer to meta-analyses. And I don't want to, confuse with a lot of statistical stuff, because I don't understand exactly the way it's done either. But these are analyses that combine the results of multiple different scientific studies. For example, what is the effect of exercise on fatigue? And then they'll collect them all together. And as a collection, they'll have a larger number of individuals who have participated in the studies. And even if a study is maybe going one way or the other, when you collectively put all of them together, you might get more statistical power that will allow you to make an estimate of the effect size. That is this a big effect or a small effect? And also be able to tell you perhaps about what are known as hazard ratios. It's twice as likely, 3 times as likely, 4 times as likely, or something like that. But it allows you to contrast results from different studies and identify patterns among these study results that would not be so obvious when you just looked at one study alone. In addition, you can then look at anything. You could look at disability measures. We talk about the Expanded Disability Status Scale, the EDSS, relapses, the number, the annual rate, MRI outcomes. We look at these all the time in studies, but we also can look at a variety of other things that are sometimes less studied, like quality of life measures with a number of different subscales, or various symptoms such as fatigue, mobility, balance, pain, and others with various different scoring systems. And so that's the way these studies have been done, and they've been done when they're collected together, and you try and look at a whole bunch of ones at the same time in these so-called meta-analyses. There are limitations to meta-analyses, though, however. The quality oftentimes varies between the studies. There may be dissimilarity of outcomes measured. There might be one fatigue scale or a different fatigue scale, and they're not necessarily the same thing. And also some of these meta-analyses might include just 2 studies. It's not much of a meta, it's a couple studies. And some might have, as I'll show you with exercise, 15, 20, or 30 different studies that might be relevant. And then there are also biases that can occur. And I'll show you that this is all formally dealt with when you look at these meta-analyses. And some of the biases might revolve around, are they randomized or not? Is there deviation from the intended interventions? That is, did everybody actually do everything that was actually supposed to be done in the study, or did only a small subset of people actually finish the study? And there might be biases in the measurement of the actual outcome. That is it something that's relatively more objective? And then there's even publication biases and other biases like that. But you ultimately can come up with, as it says on the bottom there, an overall risk of bias. And if there's a lot of red there, then that means there's perhaps a problem with the meta-analyses not having good outcomes that would be believable. You can also do something called a network meta-analyses. And these are when you it's a technique to compare 3 or more interventions simultaneously in a single analysis by combining both direct and indirect evidence across a network. So you can imagine here, if A is compared to D, let's call this exercise and fatigue. A is compared to D, this is one intervention, D is a different intervention. A is compared to B, a third intervention. And you can look at all three of those and you'll see that D is compared to C, and C is also compared to B, but it's never been compared to A. And from this, you can actually sort of rank order these, and you can compare things that have never been directly compared to each other, but indirectly compared by looking at all of the studies together. So we also want to look at what's the background of what goes on with people with multiple sclerosis and what are some of the common things we'd like to try and look at. And we know that it's not surprising to hear that physical activity is somewhat decreased in people with MS and sedentary time is increased, which might lead to a variety of different issues. All of the studies that have been performed show less activity and more sedentary function overall in MS patients, which may put people at risk of weight gain, diabetes, cardiovascular disease, and is modifiable to some degree, especially when people are younger with less disability. And I'm going to show this slide here and go over a little bit what this represents in terms of a meta-analysis. So in a meta-analysis, you're going to see the 0 point, and everything to the left here would be more common in MS patients. Everything to the right would be more common in controls. And you can see if when you take these 4 studies together, for example, you can do the meta-analysis and you see statistical significance. Anything less than 0.05, so this is 0.044, is statistically significant. And it's different from, or right about, just about abutting this 0 point here. And so in this case, it just shows that there's indeed more sedentary activity amongst people with MS. What about light physical activity? Well, light physical activity is slightly more common in people who are not with MS. And you can see there's very consistent findings that 4 out of the 5 studies in this, the one here not showing it, really show a consistent pattern, but several of these are not statistically significant. When taken together, they are statistically significant. And there's slightly more physical activity, that's light physical activity, in people without MS. The biggest difference, however, and you can see a difference in effect size here and consistency, all 5 of these studies show that with regard to physical activity, that people with MS are relatively less and more so in the greater in the control group. And the effect size is quite large relative to these smaller ones that are closer to 0. So very consistent and a relatively large effect size, and not surprising for vigorous physical activity. So does this then manifest itself with cardiovascular risk factors that are more common in MS because of that, like obesity or diabetes or high blood pressure or other things like that? There's very inconsistent results with this, with cardiovascular risk factors overall, with BMI, with hypertension. And there's no or mild difference with all these other factors that are noted here, with the possible exception of slightly higher glucose intolerance in MS patients and slightly higher cholesterol. So not a lot of evidence for cardiovascular risk factors being more common in MS patients. But if you have cardiovascular risk factors or some other risk factors, does that matter? And from at least one study, this is the CombiRx study, which is an older study that compared the combination of Avonex plus Copaxone to either one of those alone. And during this 1,000-person 7-year study, the largest study we ever did at the time, a large amount of so-called comorbid conditions were included in the analysis. And they looked at high blood pressure, high cholesterol, diabetes, depression, anxiety, and migraine. And they looked at the impact of these comorbidities on any disease activity. In this case, it's a protocol-defined relapse. And actually, interestingly, high cholesterol and anxiety were associated with a higher risk of a protocol-defined relapse. And then they just looked at, again, for a variety of different outcomes, whether if you had 1, 2, or 3 of these compared to someone with 0 of these risk factors, was there an increased risk in a variety of things? And the only thing that seemed to show up was that there was a slight increased risk likely with protocol-defined and protocol non-defined relapses. But these other factors, such as worsening of disability, combined activity on MRI scans, really no impact of these other comorbidities. So not a huge amount of data supporting that cardiovascular risk factors or other risk factors have a big impact on several things that are measured, at least in this study. So if you come to our clinic, I would hope that every single one of the doctors that you've seen in the advanced practice providers would have said that exercise is a good thing. And there is evidence, good evidence, supporting that you can have an impact with exercise on fatigue, cognitive function, memory, and as well as overall cognitive function, depression, anxiety, pain, upper and lower limb function. and actual just participation in a variety of social events. And I'll just show you some of that data very quickly here. So exercise and fatigue, this is a gigantic table here. But you can see, again, here's the 0 point. This is favoring exercise on the left, favoring control on the right. And many of these types of exercise have been shown to be quite effective for this in these studies. And sometimes the effect sizes are relatively large. And the main types of exercise looked at here were endurance exercises, aerobic exercises, muscle power, just with weights and things like this, task-oriented exercises. Those are ones that focus on actual tasks that you do on a daily basis, walking, typing, any of a variety of things like that. It seems to be most effective with endurance or mixed and other training. And these are mostly safe. That is, there's no increased risk of relapse or disability progression. You do sometimes have to be careful that you're not doing an activity that might excessively raise your body core temperature. And maybe if you have a weak leg, that gets weaker and you could, for example, fall off a treadmill, that would not be good. But otherwise, it's overall relatively good. Mostly these are in relapsing MS patients. And one of the downsides of this is that many of these studies use very different fatigue measures, so they're not necessarily all comparable. And this is what you see with a network meta-analysis. It tries to get at the question of, well, is there one type or another that is better exercise? And all the ones, again, to the left here are showing that there's benefit, and the ones that are closer to 0 or on 0 or cross over with confidence intervals really have not shown much in the way of benefit. And you can see that sort of pictorially defined on the left here. But balance exercises, cognitive behavioral therapy, general exercise, resistive exercise have the biggest impacts, and combination exercises, as noted in the other paper I showed a minute ago. So a variety of different types of exercises can have a very profound effect on fatigue. What about cognitive function? We say you can exercise your body and your brain to help with your cognitive function. That's true, but this is just regular exercise function. 21 studies, 83 effect sizes, and it's represented differently on this table. But impacts on memory, impacts are better actually in people over the age of 45 and with relatively higher levels of disability. If you do it more often, it's beneficial. If you use multi-component training, so again, a combination kind of exercise is better. If you do a duration that's less than 60 minutes, but you do it for a longer period of time, that is for many more weeks, you get more benefit. So doing it frequently to not too much exercise, you don't get over-exercise, and for a more prolonged period of time, you can have significant impacts on cognitive function. And type of exercise, does it matter? I've sort of alluded to that already in a network meta-analysis of 45 different studies comparing aerobic, resistive, combined, sensory motor, and other types of exercising. Sensory motor training had the largest effect size, and ignore the Sucre effect, it's a statistical outcome, effect on quality of life. And that's why I mentioned this particular meta-analysis, because it looks specifically at quality of life and how do you feel about how your life is going. And in this case, for quality of life, was best for people with mild disease for effect on total quality of life. Aerobic exercise was best for severe disease, and again, for direct effect on total quality of life. So multiple different types of measures, cognitive measures, quality of life measures, fatigue measures, have all been shown to significantly have impacts from exercise. How about mood and other things like that? Not as much data on this. This is for anxiety, and you can see that this overlaps with the 0 point here, only 4 studies that looked at this. And there are very small numbers in these studies. Anxiety was not the primary outcome, I don't think, in any of these studies. There are a lot of bias concerns here. So essentially, we can't say much that you have data that is representative or useful with regard to anxiety related to depression, to exercise. But there is some data for depression. There's quite a few more studies. Many of these were non-significant by themselves. That is, they overlap the 0 point here with the 95% confidence intervals. But you can see that consistently, they did show a benefit, but it was not statistically significant. When you add them together, it is statistically significant, and the effect size is actually pretty good. So exercise may well have an impact on depression, even if it's not been shown for anxiety. Mindfulness. Mindfulness is essentially meditation. This can be delivered either in person or with online approaches. And it's a type of meditation in which you focus on being intensely aware of what you're sensing and feeling in the moment without interpretation or judgment. And practicing mindfulness involves breathing methods, guided imagery, other practices to essentially relax your brain, your body, and your mind to help reduce stress and potentially help with sleep and with other things. And mindfulness has been shown to have a variety of different benefits in MS with regard to sleep, stress, anxiety, depression, and chronic pain. And now here, if you look again at overall mindfulness with regard to quality of life, quite a few measures here, different studies were done, and they all were pretty consistent together, though they are much more powerful than either one individually, because a lot of these were not statistically different, although they were consistently positive. And when you look, when you take them together, it was statistically significant. So again, using a meta-analysis, you can have much larger numbers. You can get up to 800 patients in these various different studies, where individually this patient study were very small. And if you look at comparators, you can compare different types of subgroups compared to other types of interventions for quality of life. And it actually does pretty well. Mindfulness does as well or better than a number of different comparators. And in this particular study, a lot of these were different comparators. So they were not necessarily all the same, but again, not necessarily statistically significant by themselves, but they were when taken together and had over almost 500 patients. When you look at mental quality of life measures, same outcome you can see, statistically significant for quality of life. What about massage and manual therapies? And there's a sort of a fancier version of massage that some people feel is somehow different, called reflexology. It's used quite a bit in England. And they're listed as just massage, M or R for reflexology here. And there have been positive effects seen with fatigue, pain, muscle spasms, but no particular benefit in overall physical function or psychological state. And so while we think massage is really good, for example, for people that maybe have spasticity and cramping and other things in their legs and arms, it can be quite useful overall, and frankly just feels good. Virtual reality is something that's become very commonly used for a variety of different things. First of all, just for fun for a variety of people, but it's also been used in a therapeutic sense for a variety of different conditions. And it's been studied in MS in quite a few studies. And they looked at, for example, in one meta-analysis at fatigue reduction and compared it to conventional therapy. So CT is conventional therapy here versus no intervention, or a combination of virtual reality plus conventional therapy, and looked at whether or not it was better than conventional therapy alone. And in this particular meta-analysis, the fatigue reduction was better than conventional therapy, and it was not better than no intervention, which is kind of unusual. I'm not sure why that would be the case. And when you combine the two together, it was not better than conventional therapy alone. So that shows some inconsistencies in this and doesn't seem to make a lot of sense. And so that's the kind of thing that can sometimes happen when you do these meta-analyses. When they looked at quality of life overall on the bottom here, again, it was overall better versus conventional therapy, again, not versus no intervention. And again, it was no better than conventional therapy when the two were combined. And so this is just some examples and showing some of the inconsistencies. You get a lot of different answers here. And at the top, the NI, this is the no intervention. CT is conventional therapy, and then the combination of the two versus conventional therapy. And the results are sort of all over the map. But if you look at compared to conventional therapy alone, it actually was better. It favored virtual reality, and that was for fatigue. For impact of MS, just in a symptom way, showed slightly different outcomes, but versus no intervention here, it was better, but was not better than conventional therapy, the opposite of the one before. And again, the combo did no better. And for quality of life, similarly, it's sort of all over the map a bit here, but was better than conventional therapy alone. And similar kinds of very inconsistent results when looking at balance and fear of falling. Fear of falling is a significant limiter of people's function with MS. And these results are highly inconsistent, high bias risks. A lot of people didn't complete a lot of the outcome measures. So there's really nothing useful that can be said about that. Yoga. Yoga is a very useful thing, we think, for balance, and it has a number of different benefits that have been identified. And for quality of life, one of the questions would be, is it better or not? And in the meta-analysis, it was no better than usual care and exercise on overall quality of life and multiple subscales. So it's probably got some benefit, but not tremendously large. For fatigue, it was definitely better than usual care and equal to exercise. And as we showed, exercise has a profound effect on fatigue. So this is another example of a type of exercise that can be useful for fatigue. And here's just the effect that's seen here. And at the top, these are versus usual care, and below versus exercise. And compared to usual care, very consistent and definitely better than usual care. No better than exercise though, and not a surprise, but that's still a good outcome because exercise is useful for fatigue. Similarly, for quality of life, studies were done versus usual care and versus exercise, and actually very few studies, and no benefit was really shown here. Pilates. There have been some studies looking at Pilates and impacts on balance. The Berg balance scale is a very commonly used scale, as well as activity-specific balance confidence scales and timed up and go. That literally is how you get up out of a chair and go and walk a certain distance. And there are some positive benefits from that. No impact on a functional reach test, however, and compared to other therapies, was no better than fatigue. But again, the other therapies are primarily exercise, so that's not a bad thing. That means it's probably equivalent to other exercise type therapies. And that's just looking at the balance score for the Berg balance score, where it was clearly just barely significant. And here's an interesting phenomenon here. You can see that one particular study really drove this outcome. When you see a meta-analysis and you see one particular one that drives the outcome, that should raise questions. These are all really close to zero or zero, and then one drives its outcome. So that always can be sort of a red flag. You see the same thing when you look at the time up and go. It's the same study. Again, one study really drove the outcome, and this one was borderline statistical significant. So this is a problem with meta-analysis. If you have one study that really pushes in one direction or the other, it can really perhaps give you some bias. Smoking. A number of studies have looked at the outcome of smoking. And with a meta-analysis done in 2018, ever smoking was worse than not smoking ever with regard to disability, EDSS. And ever smoking was no worse, however, in reaching various milestones on this EDSS score, or the multiple sclerosis symptom score, or a brain volume study. So that's sort of a mixed message there. We all know that smoking bad for a number of other reasons. And so this is from a different study that looked at, I'm sorry, this is the same study rather, showing that the small benefit here and no difference on reaching these different milestones of EDSS-3 or EDSS of 4. But if you go back and look at the numbers there, the numbers are actually pretty small. I mean, there's 1,200 patients or so in these studies, and this one had up to 4,000 when you're looking at the mean EDSS difference. But more recent studies have been done, and from these studies, and it's reviewed in this paper here that was just published a couple of weeks ago, continued smoking was associated with higher disability, higher MS symptom scores, reaching disability milestones faster, increased MRI activity and brain atrophy, as well as increased fatigue and depression and a lower quality of life. And cessation was associated with deceleration of disease progression. And from this study, it's the same one I just mentioned. This is a Swedish registry, has almost 10,000 patients, 15-year follow-up. So it's almost a meta-analysis amongst itself, and showed all those things that I just said. And also looked at passive smoking. And you have, for those who are subjected to passive smoking, a higher baseline disability score with current exposure versus never exposed, faster disability progression with current or prior passive exposure, and increased risk of reaching milestones. So I think this is an example where one large study probably trumps a bunch of smaller studies combined into a meta-analysis. I think we all agree smoking is probably not a good thing. Diet, we could have done the entire discussion about diet. And so I really just looked at meta-analyses that looked at diets overall. And what I say in the office is that the studies are all low quality, which is true. And Mediterranean or Paleolithic diets are the ones that seem to show the most benefit on fatigue and with quality of life. But really, mostly the studies are not well done. They're usually small. They have bad outcome measures. They're very short, and it's extremely difficult to control for diet when you do these studies. So I'm not sure we'll ever have really a dietary study that is convincing, but as of now, these would be the recommendations, but they'd be very low level of recommendations. And similarly for vitamin D, multiple studies show a clear, consistent effect of low vitamin D in terms of risk of developing MS and worse outcomes when you measure someone when they're diagnosed or when they go on a medication. It's been extremely difficult, however, to show that if you take, for example, those individuals with a very low vitamin D and raise up their vitamin D, does that change their outcome over time? The studies, again, are very low quality, including one recently that got a lot of press that really is not a very well-designed study. And so although we do recommend using vitamin D because it's cheap, it's easy, it's incredibly safe, it's probably good for bone health and other things as well, it's been very, very, very difficult to identify a substantial reduction in risk. So I'm just going to skip that last slide. So in conclusion, many non-drug behavioral changes or interventions may be beneficial in MS. And these approaches are testable. And I showed you a bunch of data and meta-analyses and even network meta-analyses. And so sometimes those analyses are good. Sometimes they're hampered by poor quality, limited numbers, biases, and other things. And so you really have to look at them with not necessarily cynicism, but you want to make sure that you analyze them as best you can. But it just reinforces that self-care is an important aspect of living with MS from the time of diagnosis all the way through your lifespan. And so these things will change. We'll get more information over time, but you can do things yourself that can be beneficial. So thanks very much. And we're going to take a small break, and then we're going to answer a whole bunch of questions.